Hello everyone, I am Dr. Navin Agrawal, Professor and Head, Department of the ENT, Index Medical College and Research Center. Today I am going to discuss the diseases of the tonsils and adenoid, that is adenotonsillar diseases. Adenoid and tonsils are the part of the lymphoreticular system and they are having the open crypts on one end and on the other side they drain into the lymphatics. Lateral surface of tonsils or bed of tonsil is formed by the superior constrictor muscle, styloglossus muscle, styloid process, glossopharyngeal nerve, peritonsillar space, pharyngobasilar fascia, and tonsillar capsule. While the medial surface of tonsils are covered by the stratified squamous epithelium and with 8 to 10 crypts extending deep into substances of the tonsil. Largest crypt known as the crypta magna near the upper pole. Epithelial lining of the crypts in the thin and semi-permeable, thus helps in sampling ingested food for immunology purpose. Acute inflammatory condition of palatal or facial tonsils involving mucosa, crypts, follicles, or tonsillar parenchyma is known as acute tonsillitis. It can be acute specific and acute non-specific. Specific includes diphtheritic, infectious mononucleosis, and insect. The most common etiological factors, as far as the microorganisms are concerned, the viral in virus it can be influenza, virus, or viruses. While in bacteria group, it can be beta hemolytic streptococcus pneumoniae, Haemophilus influenzae, and pneumococcus and Moraxella catarrhalis. Types of non-specific acute tonsillitis are peteral, cryptic, acute follicular, and acute parenchymal and ulcerative. These are the clinical types of acute tonsillitis. The most common symptoms of acute tonsillitis is fever, then body ache, malaise, odynophagia, dysphagia, earache, dry cough, sore throat, abdominal pain, and halitosis. Signs most commonly congested tonsils. We can see along with the enlargement of the tonsil, that is diffuse swelling of the tonsil, crypts filled with the pus and swollen follicles, membrane over the tonsil, and enlarged and tender buccal-digastric lymph. In cases of acute tonsillitis, we can go for the CBC, peripheral smear, throat swab for culture and sensitivity, monospot test, pulmonary test, ASO titer, X-ray, soft tissue nasopharynx, X-ray PNS, and USG. We have to differentially diagnose the case of acute tonsillitis with certain other diseases such as partial diphtheria, infectious mononucleosis, Vincent angina, scarlet fever, agranulocytosis, leukemia, aphthous ulcers, HIV, secondary infections, syphilis, and candidiasis. The treatment, the mainstay of treatment is take rest and hydration along with the antiseptic gargles, antibiotic, mainly the penicillin group of antibiotics, or macrolides can be given, analgesics such as paracetamol or NSAID. Complications of acute tonsillitis can be peritonsillar abscess, parapharyngeal abscess, intratonsillar abscess, septicemia, glomerulonephritis, rheumatic fever or arthritis, and endocarditis. So these are the different pathologies other than the acute tonsillitis, such as partial diphtheria caused by the coronabacterium diphtheria, rare due to immunization, and fever with raised pulse out of proportion to fever, joint pain, and white membrane over tonsils and pharynx are the cardinal signs for, and it can bleed the tonsil or the area can bleed after removal of the membrane. Vincent's angina, acute ulcerative lesion of pharynx, tonsils or soft palate and gums, overcrowding, poor nutrition, and dental caries are the most common predisposing factor, while the fusiform bacillus or Spirochete denticola is the etiological organism. The most common presenting symptom is sore throat, fever, severe pain, fetor oris, ulcers covered with grayish membranous slur. Infectious mononucleosis, it is caused by the Epstein-Barr virus. Young adults presented with the sore throat, tonsils, congested over covered with slough, fever, lymphadenopathy, hepatosplenomegaly. Treatment is mainly symptomatic, takes few weeks to recover. Scarlet fever is another entity which is caused by the group A streptococcus. It includes sore throat, fever, headache, swollen lymph nodes, and a characteristic rash. The rash is red and feels like sandpaper, and the tongue may be red and bumpy. It most commonly affects young children. Rash is due to the erythrogenic toxins. Chronic tonsillitis. Chronic inflammation of palatine tonsils is a result of repeated attacks of acute tonsillitis or due to inadequately resolved acute tonsillitis. Beta hemolytic streptococcus microabscess walled up by the fibrous tissue seen in lymphoid follicles. Clinical types: chronic follicular tonsillitis, chronic parenchymatous, and chronic fiber. Symptoms: 3 to 4 attacks of sore throat in a year, cough, halitosis, bad taste in mouth, thick speech, difficulty in swallowing, and sometimes sleep apnea can be there. Cardinal signs of chronic tonsillitis. These are the collectively known as the Irwin Moore sign. Not collectively as such. Irwin Moore sign is whenever you press the tonsil with the help of the tongue depressor, some cheesy material coming out from the upper hole or the crypta magna. That is Irwin Moore sign, and it is a cardinal sign for chronic tonsillitis. Other than this, there can be bilateral or unilateral jugulo-digastric lymph nodes. They are palpable, non-tender, and some patient can present with the hypertrophy of the tonsils with the anterior pillar congestion. Grading of tonsil in parenchymatous tonsillitis can be graded as grade 1, 2, 3, 4, which you can identify by assessing the size of the. This is the Paradise criteria. Sore throat are due to tonsillitis. The episodes of sore throat are disabling and prevent normal functioning. 7 or more well-documented, clinically significant, adequately treated sore throats in the preceding years. 5 or more such episodes in each of the preceding 2 years. 3 or more such episodes in each of investigations. Well, we would like to go for the CBC, BTCT, PT, peripheral smear, blood grouping, ASO titer, X-ray, such as even for in chronic tonsillitis case. Treatment mainly conservative or the oral hygiene because of the advent of the new antibiotics. Mainly conservative treatment is sufficient. Diet treatment of dental, nasal, or sinus infection, but sometimes tonsillectomy is also required in cases of the tonsillitis, chronic tonsillitis. Complications can be peritonsillar abscess, parapharyngeal abscess, intratonsillar, same as such of acute tonsillitis. Adenoid is the hypertrophied mass of lymphoid tissue situated at the junction of the roof and posterior wall of the nasopharynx. It is the part of the Valdears. Etiology: recurrent attacks of rhinitis, sinusitis, or chronic tonsillitis may cause chronic adenoid infection and hyperplasia. Allergy of the upper respiratory tract may also contribute to the enlargement of the adenoid. Nasal symptoms. Main nasal symptoms are the nasal obstruction, nasal discharge, sinusitis, epistaxis, and voice changes. Oral symptoms are tubal obstruction, recurrent attacks of the acute otitis media, chronic suppurative otitis media, and otitis media with general symptoms, adenoid faces. Chronic nasal obstruction and mouth breathing lead to characteristic facial appearance called adenoid faces. The child has an elongated face with dull expressions, open mouth, prominent and crowded upper teeth, and hinged up upper lip. Nose gives a pinch in appearance due to disuse atrophy of the laminae. Hard palate in these cases is highly arched as the molding action of the tongue on palate is low. Pulmonary hypertension can be seen and abrosexia. This is the picture of X-ray soft tissue nasopharynx lateral view. You can see the adenoid hypertrophy in the nasopharyngeal area, which is causing compression over the. This is with the open, so that we can see the entire windpipe, that is trachea, but it is compressed here, or airway that is compressed. The trachea is starting below the. Treatment, only treatment option uh, is adenoidectomy if they are enlarged or grade 3 and above. But if patient is having grade 1 or grade 2 and mild symptoms of adenoid hyperplasia, then we can also give some nasal decongestants, antibiotics, and systemic decongestants such as pseudoephedrine and montelukast and levocetirizine form. Thank you.